Yes.
Good evening, everyone. So, once again, we welcome all of us to today's MCQs, day two. Once again, I want to say thank you for joining. Today, we start with question 26. So, if our colleague who is doing 26 is already on the call, kindly proceed. Dr. Mojid.
Hello, good
Yes.
evening, Dr.
Good
Eugene. Hello,
Okay, Amina, you are on.
Amina is here. Can I take
Okay.
number 24 so that
Yes,
we
yes,
can continue?
yes.
Good evening, everyone. Sorry.
Kindly go ahead. I'll go to the 24 soon. Just a second.
Okay.
And so, Dr. Mojid, Dr. Amina asked permission to do the 24 before we proceed. So, kindly.
No problem. No problem, sir.
Thank you.
Yes.
Okay. I think you will have to shift it a bit. Okay. All right. Good evening, everyone. I'll take question 24. I wasn't able to take it yesterday. So it goes as, which of the following statements regarding measurement of cardiac output is correct? A, in the thermodilation method, cardiac output is directly related to the area under the thermodilation curve. B, the thermodilation method tends to underestimate cardiac output in low output state. C, in the presence of tricuspid regurgitation, the thermodilation method is preferred over Fick technique for measuring cardiac output. D, a limitation of the Fick method is the necessity of measuring oxygen consumption in a steady state. And E, cardiac output is directly proportional to systemic vascular resistance. So this question is talking about the invasive methods of measuring cardiac output. There are two techniques. There used to be three techniques. Initially, there was the Fick technique, then the dye technique, and then the thermodilution technique. But now we use just the Fick technique and the thermodilution technique. The dye technique is no longer in use. So I will just go briefly just talk about the two techniques, the principles behind them. So let's start with the Fick technique. The Fick technique uses the Fick's principle. The principle states that the amount of substance taken up by an organ, in this case, we are talking about the human body, is equal to the product of the blood flowing through the organ. So it's equal to the product of blood flowing through the body in unit time and the arteriovenous difference of that substance. Here it is the oxygen. So what it means is that the amount of substance flowing up, taken up by the organ, that is the amount of oxygen taken up by the body, is equal to the product of blood flowing through the body in unit time, and then the arteriovenous difference of the oxygen. In other words, the cardiac output is flow through the whole body in unit time. So if you want to use the Fick principle to measure cardiac output, it means that the rate of oxygen absorbed by the whole body is measured, and then a formula is used. So the formula is cardiac output is equals to the oxygen absorbed per minute by the lungs divided by the arteriovenous oxygen difference. So if you have the value of oxygen absorbed per minute by the lungs, then you get the oxygen difference between the atrial oxygen and the venous oxygen. So just one needs to take a blood sample from the systemic artery and then measure the partial pressure of oxygen. Then take a mixed venous blood sample from the right atrium or pulmonary artery invasively, and then measure the partial pressure. So the difference between the oxygen in the arterial circulation and from the venous circulation is what will give us the difference between the arteriovenous oxygen. So if we have the oxygen absorbed per minute by the lungs, we just divide it by the difference in the arteriovenous oxygen, and that will give us the cardiac output. So the drawback of this method is that one needs to have a steady, one needs to measure oxygen consumption in the body at a steady state, because the whole cardiac output depends on the oxygen consumption. So this is the drawback of the Fick's method. Then the thermodilution method, in this case, is a technique that is used using temperature. So what is done is that a pulmonary artery catheter is inserted from the right atrium, goes through the right ventricle, and then to the pulmonary artery. So when the catheter is inserted, it is inflated and then fixed within the pulmonary artery, then deflated. After being deflated, then a cold saline or dextrose is injected. So the principle is that as that cold saline moves from the right atrium to the right ventricle and to the pulmonary artery, temperature changes are measured because the catheter is within these chambers of the heart, and then the temperature within the cold saline is mixed with the temperature of the blood as it passes from the right atrium to the right ventricle to the pulmonary artery. So this temperature change is measured as it gets up to the pulmonary artery. And then the catheter has a thermometer at the tip. That's what measures the temperature. The degree of difference in temperature is directly proportional to the cardiac output. And this change in temperature over time is measured and plotted as a graph. So it will give us a curve, the change in temperature as plotted against time. And then this curve below it is what signifies the cardiac output. So based on the principle, in low cardiac output, the temperature change is expected to be slowly. Why? Because the cardiac output is slow. So you can imagine this the speed at which the cold saline or the dextrose moves from the right atrium to the right ventricle to the pulmonary artery, it becomes slowly. So this indicates low cardiac output. While in
Mommy, what do you mean?
Can I go on? Somebody is
Please go ahead.
okay. Then in high cardiac output, the temperature is registered very fast. So this is what happens in the thermodilution method. This is done like 3 times and then an average is taken. Now there are modern catheters that have elements within them that intermittently heat and cool the catheter so the temperature can be measured without following through the process of the re-injection of the cold saline. So once we inject one time, the saline can be heated up and the temperature change can be measured. So when we plot the graph between temperature change and time, we have a curve. The curve is longer. That means the area under the curve is wider if there is low cardiac output. Remember, with low cardiac output, the change in temperature is slow. So if it is slow, it means that the curve is long, but horizontally. Then in high cardiac output, the change in temperature is rapid. So the curve is shorter and higher. So it goes high up and then falls down. So that's the difference between high and low cardiac output in terms of the curve. So let's go back to the question. So the difference, the first option is in thermodilution method, cardiac output is directly related to the area under the thermodilution curve. So this is wrong because it's indirectly related to the area. The longer the area, the lower the cardiac output, and the higher the area, the higher the area, that is the area of the curve, and the higher the area means the height, but the area covered under the curve is short. So the smaller the area under the curve, the higher the cardiac output. Meanwhile, the larger the area under the curve, the lower the cardiac output. So this option is false. Then option B, the thermodilution method tends to underestimate cardiac output in low output states. This is also false. In low output state, when there is the output is in low output states, as the temperature is moving, as the substance, whether it's saline or dextrose, is moving from the right atrium to the right ventricle to the pulmonary artery, because there is a low output state, it takes up time. It takes up time. So, and these substances, this temperature is being absorbed by the structures around the heart. So that absorption of temperature the temperature change is rapid instead of it being slow. So all these, rather than the blood, other structures within the heart also absorb temperature. So the rapid change in temperature will tend to overestimate the cardiac output. Remember, the more rapid the change in temperature, the higher the cardiac output. So option B is wrong because thermodilation method will overestimate cardiac output in low output state. Then option C, in the presence of tricuspid regurgitation, the thermodilation method is preferred over Fick technique in measuring cardiac output. This is false. The thermodilation method is, it gives an error in tricuspid regurgitation because there is a turbulence of blood during in tricuspid regurgitation, front and back, a large volume of blood. And remember, in thermodilation method, we want a forward movement of blood and we are measuring the temperature change. So with all this turbulence of blood in tricuspid regurgitation, it's better not to use the thermodilation method because it will give an error. So option C is false. Then option D, a limitation of Fick method is the necessity of measuring oxygen consumption in a steady state. This is true. I mentioned it earlier that the Fick method, this is the drawback. One needs to measure oxygen consumption in a steady state in the human body so as to have the accurate cardiac output. So option D is the correct answer. Option E, cardiac output is directly proportional to systemic vascular resistance. This is false. Human physiology, cardiac output is inversely proportional to systemic vascular resistance. So the answer to this question is option D. I hope it's clear enough. Thank you.
Thank you. Any questions, contributions? Okay, in the absence of that, we go to our question for the day. Thank you, Dr. Amina. 26.
Yeah. Good evening, Mars and SARS. Standing on a system protocol, I'll be taking question 26. And the question goes thus. A 66-year-old woman is referred by her primary care physicians. I hope you are hearing me.
Loud and clear, please.
Okay. For further evaluations of dyspnea on exertion. On examination, both an opening synapse and mid-diastolic rumble are appreciated at the apex. An echogram is obtained. Now the question is, which of the following cannot be assessed from the transmitral Doppler tracing shown above? Now, looking at the descriptions in the question, the opening synapse and the mid-diastolic rumbling murmur is in keeping with auscultatory findings in the patient that has a mitral stenosis. Now, if you look at that figure 1.4, it's showing a colored Doppler spectral tracing of a transmitral flow. Now, above the baseline is the prior tracing that occurs at diastole. If you notice, the decline, the deceleration of the transmitral inflow, however, is prolonged because of the narrowing of the mitral valves that allow for continual pressure difference between the left atrium and the left ventricle. Now, if you look below the baseline, is the spectral tracing of a mitral regurgitation that occurs at asystole. Now, if you trace the spectral tracing above the baseline, it will give you an idea about the pressure gradients It can give you information about the maximum velocity. And if you trace, we can also get information about the prayer of time across the mitral valve. Now, and that's the time taken for the velocity to be halved. Now, if you trace from the apex down to the base, that midpoint will give you the prayer of time. And usually based on this current machine, they are calculated automatically. Now, going back to the question. Question A says the presence and the severity of mitral regurgitation. The presence and severity of mitral regurgitation. Yes, we could have an idea of what the severity of the mitral regurgitation is using the formula, the mitral valve area, which is equal to which is equal to 220 divided by prayer half time. That means the option A is false because they said cannot be assessed. It's a true statement, but based on the question, it's going to be false. Now, the option B, the presence of mitral regurgitation. I said earlier that spectral wave below the baseline. Spectral wave below the baseline is for the mitral regurgitation. That means the answer is also true, but it's going to be false based on this question. The transmitral Doppler pressure gradients also can also be assessed because if you trace this thing, I've said it earlier, give you information about the velocity, the mass velocity, and the pressure gradient across the valve. Also mean that it's a true statement, but based on it's also going to be false. The etiology of the valve lesions. The etiology of the valve lesion cannot be depicted from the picture above, meaning that would be the true statement for the true answer for this question. The mitral valve area too can also be gotten from this. Now for question 26, the answer is D. The answer is this for question 26. I hope I can move ahead. Now,
if they are not
37,
but just a comment. Just looking at the spectra too, it can give you an idea of indirectly the severity, even if you don't calculate the valve area using the pressure half time, as in what you described earlier. If you notice, the transmitral inflow does not have an A wave. You don't see an obvious A wave. We literally see just a single wave. Understand? So the absence of the A wave in a patient who has mitral valve stenosis and with such a slope is likely suggestive that the mitral stenosis is so significant that patient likely the left atrial dilatation is significant and it's in atrial fibrillation. So you are losing the A component. That could also be something you can infer. It's not absolute, but if you look at it and you're not seeing an A wave, it can tell you that it's possible this patient has an atrial fibrillation, and so indirectly the left atrium is markedly dilated from the MS, so likely a severe MS.
Okay, sir. Thank you, sir. Now, for question 27, a 37-year-old woman with no significant past medical history present to the emergency department with acute shortness of breath and pruritic chest pain. Her only medication is an oral contraceptive. On examination, is notable for sinus tachycardia. The chest computer tomography shows subsegmental pulmonary emboli, and she started on anticoagulation therapy. The echogram is performed that demonstrates the Marconi signs, as well as microscopic regurgitations with the following values. The peak systolic velocity across the valve is 3 meters per second. The IVC diameter is 1.9 centimeter with less than 50% collapsibility with inspiration. Which of the following statement is correct? Now, looking at this question, it's just giving us an information about a patient that developed an acute pulmonary embolism. The likely risk factor is the oral contraceptives, and the The CT scan was done that demonstrated the subsegmental pulmonary emboli, and on echo, they saw Marconi's sign. And what is Marconi's sign? The Marconi's sign is usually described as when you have a right ventricular wall hypokinesis or dyskinesia, usually the mid area with apical sparing. And that's what Marconi's sign is all about. Now, going to the question, which of the following statement is correct? The Marconi's sign referred to localized dyskinesis of the right ventricular apex in patients with acute pulmonary edema. Usually it spared the apex, making this statement to be false. Though their Marconi's sign is said to be specific for acute pulmonary embolism, but there is not all Marconi's signs that are pulmonary edema. You can also see Marconi's sign in patients that have a right ventricular wall ischemia or myocardial infarction. Now, the second is the Cosmos sign may result from acute pulmonary edema. This is a true statement because in the patient that has a strain on the right ventricle, there is issue with ciliation of the right ventricular wall. Because of that, with inspiration, that we expect that the jugular venous pressure should decrease. It rather increase in these settings. And there are other causes of that could behave like this: right ventricular hypertrophy, somebody with cardiomyopathy, and pulmonary causes could also cause this. Now, the patients, and that makes the answer to be a true statement. This patient's estimated pulmonary arterial systolic pressure is 64. Now, going back to this question, if you look at the pressure gradient across the T valves here, now using Belloni's equation, 4 multiplied by 9, 3 square will be 9, and this will be 36. Now, looking at the IVC diameter, which is 1.9, meaning that it's less than 2.1, and the collapsibility is less than 50, meaning that the estimated right atrial pressure is likely, right atrial pressure is between 5 to 10. If the IVC diameter is less than 2.1 and is more than 50% collapsible, that's the RAP of less than 5 milliliter of mercury. But if it is less than 2.1 and the collapsibility is less than 50%, the RAP in that instance is 5 to 10. Now, if it is greater than 2.1 and the collapsibility is more than 50%, the RAP in that instance too will also be 5 to 10. However, when it is greater than 2.1 and the collapsibility less than 50%, and the RAP in that instance will be 15. Now, going back to this question now, with the 36 that I got and with RAP of 5 to 10, if I had it, that means the estimated pulmonary arterial systolic pressure here will be equal to 41 to 46. Now, the patient right atrial pressure should be estimated to have approximately 15. No, this is 5 to 10, making the B option here to be the true statement. Question 28. Which of the following statement is true regarding the response of healthy older adults to aerobic exercise? Now, maybe as a brief, just a brief information about what is expected, the physiological response to aerobic exercise. Now, during normal aerobic exercise, it could either be an aerobic exercise or isometric exercise. Now, aerobic exercises are exercises that usually involve somebody moving from one place to another, and examples are jogging, swimming, trekking, and all those. While the isometric are usually done in a position is aimed to increase the strength of the muscle, and that's what the isometric exercise is all about. Now, during aerobic exercise, the heart rate and the systolic blood pressure, they are usually increased, whereas the diastolic blood pressure, they are usually normal because of the peripheral vasodilation. Now, but in comparison to the isometric exercise, both the systolic blood pressure and the diastolic blood pressure, however, increases, and the heart rate will also increase. Now, because of the increase in heart rate, it's expected that in normal physiology, because of the increase in the heart rate, it's expected that the cardiac output is also going to increase. Now, in adults, older adults, because of the blunted beta adrenergic response, these usual heart rates that we see during aerobic exercise is blunted. As such, the cardiac output is expected to also be decreased because of the blunted response to the increase in heart rates. Now, and over time, in those people that are sedentary, they have a sedentary lifestyle, with each decade, it tends to have the aerobic capacity of 8 to 10 decrease. That's per decade. Now, in adults, older adults, of all the parameters that tends to decrease, the only one that is not affected is the stroke volume. The stroke volume, both in the elderly and the younger, they remain preserved. Now, going to the question, the option A said the ventricular systolic volume decreases with age, shows that there is an age-related fall in cardiac output during exercise. The stroke volume is usually preserved. The fall in cardiac output that we see in an elderly patient is because of the blunted heart rate. As such, the fall in cardiac output is usually from the fall in the heart rate. Now, that makes that one to be false statement. The systolic and diastolic blood pressure each rises significantly during aerobic exercise. Now, the systolic blood pressure rises, whereas diastolic is usually normal because of the accompanying peripheral vasodilation that occur during the exercise. That also makes this one to be false. Now, a decline in beta adrenergic responsiveness contributes to a fall in the maximum heart rate in older adults. Based on the earlier explanation, this makes this to be a true statement. Now, a normal adult cardiac output doubles during maximum aerobic exercise. Usually, it increases as high as 4 to 6-fold above the baseline. This also makes this one to be false. Now, the maximum aerobic capacity does not change significantly with age in sedentary individuals. As I said earlier, in those that have a sedentary lifestyle, per decade, they usually have a decline in aerobic capacity of about 8 to 10% per decade, also making this one to be a false statement. The answer for 28 here is C. In the absence of any questions, I will go to question 29. Now, the physiological states and dynamic maneuver alter the characteristics of heart murmur. Which of the following statements is correct? Now, just to remind us about what are the usual dynamic changes that you see with auscultation. Now, usually the right side murmurs, they increases with inspiration, except for the pulmonary ejection signs. Whereas the left side murmurs, they increase with expiration. Now, any maneuver that decreases the blood return to the left ventricle, example, Valsalva maneuver, and when you are standing from a squatting positions, tends to decrease the murmurs across the valve on the left side, except for the systolic murmur of Ockham and the mitral valve prolapse. Now, any maneuver that increases the venous return and as such increases the volume of blood in the left ventricle also increases the intensity of the murmur. Example, squatting, and when you are lying down, or passive leg raising, increases the murmur on the left side, except for the murmur of open and that of mitral valves. Now, the intensity of the mitral regurgitations, aortic regurgitations, and the murmur across the VSD tends to increase with any maneuver that increase the afterload. And the reason being that with example is hand gripping, which is a form of isometric exercise, there is an increased afterload, which increases the resistance to forward flow. As such, there is an increased amount of blood that will flow back into the left ventricle. As such, that it tends to increase the murmur across those valvular areas. Now, going back to the question, the first question says, in acute MR, the left atrial pressure rises drastically so that the murmur is heard only during late systole. Now, if you look at what happened in acute mitral regurgitations, because it's acute, the LA walls, they are still non-compliant, meaning that there is a rapid rise in the left atrial pressure, because at the onset of left ventricular contraction, there is a pressure gradient between the LA and the LV cavity, meaning that rapid flow of blood across the mitral valve will make the murmur to occur early in diastole, because as the regurgitation continues, there will be equalization of the pressure between the LA and the left ventricle, meaning that the murmur is best heard during the early systole, and that makes that one to be false. Now, rising from a squatting to a standing position causes the murmur of mitral valve prolapse to begin later in systole. This is also false. It's also early in systole. Now, see, the diastolic rumbles of mitral stenosis becomes more prominent during the streaming phase of the Valsalva maneuver. What does Valsalva maneuver do? It decreases the blood return to the left ventricle, meaning that the amount of blood that will be flowing through the stenotic valve will be less. As such, the intensity of the murmur too will also be reduced with Valsalva maneuver. That makes the C also to be false. Now, the murmur of aortic stenosis, but not mitral regurgitation, become louder during the beats after a premature ventricular contraction. This is a true statement. The murmur that occurs after the premature ventricular complexes tends to be louder during the next phase of the cardiac cycle, whereas for the MR and AR, it tends to decrease after the premature ventricular contraction, and that makes this D option to be true. The murmur of acute regurgitation can usually be heard throughout diastole. Usually it's an early diastolic murmur, because as the left ventricular end diastolic pressure builds up, it equalizes, and usually the murmur is heard best in the early phase of diastole. I don't know if there's any clarification or addition on question 29. Can I go ahead? Now, which of the following statements regarding computer tomogram of the chest shown in figure 1.5 is true? Now, if you look at the CT scan showing in figure 1.5, it's showing the tennis ball signs that is seen in patient that has an aortic dissection. And if you look at it, it involves both, on the A diagram, it involves both the ascending aorta and the descending aorta. And if you look at the B diagram, this bigger hyperintense area is the descending aorta. Now, next to it, that smaller area is the left common. It's also a dissection involving the left common carotid artery. While the next after that small one is the one that involves the bronchocephalic right bronchocephalic trunk. Now, usually, aortic dissection are graded according to the DeBakey. There is DeBakey classification. There is also Stanford classification. Now, when you have an aortic dissection that originates in the ascending aorta and propagate to the arc of aorta and the descending aorta, that's type 1 of DeBakey. Now, when you have an aortic dissection that originates in the ascending aorta and is restricted within the ascending aorta, that's type 2 of DeBakey. Now, an aortic dissection that originates in the aortic dissection, in the ascending aorta rather, in the ascending aorta, whether it propagates or not, is type A for Stanford classification. Now, the dissection that originates in the descending aorta is type 3 of DeBakey, and that's type B for Stanford classification. Now, because of the mobility and mortality associated with type A, when it ruptures, the gold standard for management of type A aortic dissection is usually surgery. While type B, if they are not complicated, and features of complication in type B are usually features of malperfusion. When you have vital organ hyperperfusion, if you realize there's an impending rupture of the descending aorta, or if there is propagation of the dissection. And those are the indications for surgery in type B. Usually, if there are no complications in type B, what it does is the medical management to control the heart rate and the blood pressure, while you follow them up with echo serially to look for any signs of that will indicate a need for surgery. Now, going back to the question, now the patient disorder should be managed medically with surgical intervention considered only. With surgical intervention considered only if there are evidence of secondary organ involvement. If you look at, as I said earlier, it involves both the ascending aorta and descending. This is actually the Stanford type A, meaning that management here is actually surgical, making the first option to be forced. Now, the left common carotid artery is paired in this process. If you look at the figure B, I said that smaller one immediately after the descending aorta is the left common carotid artery, meaning that it's also involved, also making this one to be forced. The sensitivity of computer tomography for the diagnosis of this condition is greater than 95%. This is a true statement. The sensitivity and specificity of computer tomography and magnetic resonance imaging is between 98 to 100%, while for transesophageal, the sensitivity is around 97%, while specificity is around 97%. Now, for C option is true. It said fewer than 50% of patients with this condition will report chest pain. Usually 80 to 90% of patients that has aortic dissection usually present with chest pain, also making this one to be false. Now, the transesophageal echocardiography is necessary to confirm the diagnosis. This is a false statement because the sensitivity and specificity of the computer tomography is far, far higher than that of the transesophageal echocardiography, also making this statement to also be false. Question 30, the answer here is C option. So, and that ends the number of my last question for tonight.
Thank you very much, Dr. Mujid. Do we have any contributions, please? In the absence of that, we continue with 31 with Dr. Ovunda in nature.
Well, thank you very much for the time here. I would be taking question 31, and then I'll end in 35. And it is a question talking about exercise tests and to ask whether it's true or false. So the question starts with, which of the following statements regarding ST segment changes during exercise testing is true? A, the electrocardiographic localization of ST segment depression predicts the anatomical territory of coronary obstructive disease. The next question talks about the J point being the proper isoelectric reference point on the ECG. The C talks about the J point depression during exercise being diagnostic for significant cardiac ischemia. The B talks about the persistence of ST segment depression for 60 to 80 milliseconds after the J point is necessary to interpret the ECG response as abnormal. And the last is the ST segment depression must be present both during exercise and in recovery to be interpreted as abnormal. And so we'll just try to dive into the answers for the question. So basically for the stress ECG, what we use for diagnosis is the ST segment depression. And of course, we expect that the ST segment depression to connote a positive test has to be horizontal or downsloping in configuration. So looking at the first term basically is telling us that the localization of ST segment depression predicts the anatomical territory of coronary obstructive disease. And we know that that is not true because unlike the ST segment elevation that helps us to localize vision, the ST segment depression does not have that capacity to help us to delineate the location of the lesion. So that is not what it does. If the option was an ST segment elevation, that would have been true. And also, the second option tells us about the J point being the proper isoelectric reference point. We also know that is not true because the correct isoelectric reference point for ST segment is actually the TP segment. However, just to note that during stress tests and exercise, this segment many times can be shortened during exercise. So when this happens, the PQ automatically becomes the chosen reference point instead of that. So it also does not fall in line with that. So that is not the answer. So also on that question of the J point depression being diagnostic of significant cardiac ischemia, no, the J point usually in many of the machines is set between about 60 to 80 milliseconds after the beginning of the J point. That is when we can consider whether there is a depression if it is after the 60 to 80 millisecond mark. So C is not the correct answer. For D, the persistence of ST segment depression after the J point is necessary to interpret the electrocardiographic response as abnormal, and of course that is very true. And then also ST segment depression it has to be present both during exercise and during recovery to show that it is positive, and of course that is false. Our view should be the ST segment depression that develops during exercise. Just to note that in very few amount of patients, ST segment depression may persist into recovery in a very, very few amount of patients, but we don't view or read the ST segment depression to be present both in the exercise and then both in the recovery to constitute the fact that the patient has a positive test. So from the ongoing, what we discussed, the best answer to our question is actually answer D. So for 31, we have answer D. I don't know whether we have any contribution or further explanation on what we just presented.
Just to mention that the localization on ST on stress test seems to be a recurrent question. We had a similar question on that on day one, so we should pay attention to localization by ST depression or elevation on stress.
Thank you so much, Koshret. Also, I'll be going to 32, and ECG tracing is put forward here, and it was obtained as part of the routine preoperative evaluation. Just to note that this patient is asymptomatic, and
even the room key themselves forgets.
As able to undergo a wrist surgery. The tracing is shown in sheet 1.16, and the one who find the first question is this consistent with a right ventricular hypertrophy? Is this consistent with left posterior fascicular block? Or is this reversal of limb lead placement? Is it a left anterior fascicular block and a counter clockwise rotation? Or is it dextrocardia with situs inversus? So one of the pertinent things to note about this ECG is that in our lead 1 and lead AVL, which is the upper lateral lead, we notice that the QRS complex seems to be pointing downward. So we have a prominent S wave in our lead 1 and AVL. Also interesting is that in our lead 1 and AVL, there is also a downward pointing or an inversion of the P waves. Also looking at this, we are looking at our AVRO. Our AVRO seems to be upright, the QRS complex. So we have a prominent arrow wave, which is not what we expect to see in the AVRO. And then this could be a differential for dextrocardia because, of course, in dextrocardia, we expect that the AVRO will be upright as the arrow wave. However, for us to say this is dextrocardia, we also have to look at the precordial lead. And in the precordial lead, if that was dextrocardia, we would expect that there will not be P-wave progression. So,
Hello, mute ourselves, please.
Okay, all right. So would expect that there would be an arrow wave progression, poor arrow wave progression. I will find out that most of the precordial leads will be pointing downward, But you look at the ECG closely, you find out that basically the P wave, the arrow wave is progressing positively. So that rules out a dextrocardia. Also, another option would have been a right ventricular hypertrophy. We would expect the right axis deviation. We would have expected probably the V1 to see that our arrow versus S would be greater than 1, or the arrow wave will be greater than 7, or using the Tocqueville criteria for right ventricular hypertrophy, we expect that the S in V5 or 6, and then the arrow in the V1 will be greater than 10.5 millimeters. But looking at that, that does not qualify. And then probably a left posterior particular block, where we will see a small the arrow and then the S patterns in the lateral lead at 1 and AVL, and then we see that the other pattern at the inferior lead, or the left anterior fascicular block and a counterclockwise rotation. However, looking at this ECG reading, would find out that everything seems to be located just in the AVRO, which is the augmented right. And then we also seen that PD2 is also displaced downwards. And we also see that the AVRO is displaced, AVRO rather is displaced upwards. Using the N2 triangle, the LA, arrow ALA 1, then we look at the arrow A, and then the foot will give us 2, and then the LA and the foot will give us 3. So it looks as though in this condition, actually what happened was that was actually a reversal of the lead placement. So the one that was supposed to go for the right arm was switched with the one on the left arm. So there seemed to be an LA arrow A reversal, giving us this particular pattern seen in this particular ECG. So going forward, the answer, most appropriate answer here will be answer C. All right, so please, I don't know whether we have any feedback or any further contribution. All right, can I go ahead?
Yes, please.
Yeah, Eugene, please, can I go ahead?
Yes, please, you can go ahead.
Thank you very much, sir. And so we go to the third one, the third question for me, which is question 33. And of course, we are still talking about the exercise stress test and some positions we have put forward. The first was A, regardless of the exercise protocol, the heart rate and systolic and diastolic pressures all must increase substantially to achieve a valid test. Then another one also is bicycle, treadmill, and the arm ergometry protocols all produce approximately equal heart rate and blood pressure response. Then another one was about the standard boost protocol is characterized by only small increases in oxygen consumption between stages. And the fifth, or the D, is a fall in systolic blood pressure during exercise is associated with severe coronary artery disease. And our option E, an optimal graded treadmill exercise test rarely requires more than 5 minutes of exercise in a boost protocol. So we start with the first one. Regardless of the exercise protocol, heart rate and systolic and diastolic blood pressure all must increase substantially to get a valid test. So basically, for an optimal exercise test, there has to be an appropriate rise in both heart rate and systolic blood pressure, and not diastolic blood pressure. So what we look at basically is the heart rate, and that's why usually we have a protocol for the heart rate, and of course, which is 220 minus the age, and many times we expect that the heart rate to be able to hit up to 85% of this. And so also to note that the diastolic blood pressure may fall, rise, or stay the same depending on the protocol used and the workload achieved. So we don't expect that it must have to rise up every time to substantially achieve a valid test. And so just to note that the most popular protocol usually is a treadmill protocol. So that's the most commonly used form of stress testing. We have other ones, of course, like the bicycle protocol, and this one is usually used for patients that are conditioned patients because of the ramped nature of the test. Also, we have the arm crank ergometry. It's usually used for those people who cannot perform leg exercise and patients with severe peripheral artery disease. Now, for this test, they all have what they aim to achieve. Of course, we state that the treadmill protocol is the most common and is characterized by high maximum heart rate and oxygen consumption. The bicycle is closely followed to that. The heart rates are similar to that of the treadmill, but the difference being that the oxygen consumption for the bicycle, of course, are lesser than that of the treadmill. So they are not the same. You can achieve maximum heart rate, but the oxygen consumption is less compared to that of the treadmill. In the arm type seems to appear to be like the isometric test, and in the arm protocol, there is higher heart rate and blood pressure response compared to that of the leg test, which include the bicycle and then the treadmill. So in this one, what increases in this one basically for the arm something is the higher heart rate, of course, and then the leg, and then the blood pressure. However, just to note that for this one, the maximum heart rate achieved is only approximately 70% of those compared to the treadmill or the bicycle. And then, of course, what we also note is that the maximum oxygen consumption for this one is also leg test in this context, the bicycle and the treadmill. So looking at our options, the bicycle, treadmill, arm ergometry protocols all produce approximately equal heart rate and blood pressure response. Of course, that is not true at all. Then also, as we know, one of the primary limitations of the boost protocol is the large increase in oxygen consumption, which is noticed when people go from one stage to another. People can start from 5 meds, and then the next can go to 7, can go to 9. So, of course, we know that there's a large increase in oxygen consumption from one stage to another, and that is one of the things that limits its usefulness in elderly people, in deconditioned people, or in ill people. And of course, in these cases, in such patients, we may think about more gradual regimens like the Naxin and then the Weber protocol. So these are quite different. So look at that again. The standard boost protocol is characterized by only small increase in oxygen consumption between stages. And of course, we know that that is not true. And then we also find out in option E, let's just jump D, optimal graded treadmill exercise test really requires more than 5 minutes of exercise on the boost protocol. Basically, we will need about 6 to 12 minutes of progressive exercise. So basically that really requires more than 5 minutes. Of course, it's not true. And then we expect that as the exercise progresses, we expect the blood pressure to increase. Of course, we know that because this happens, apart from the maximum oxygen consumption increasing, we also have the heart rate increasing, and all these things play a role in the blood pressure. So we expect that during the exercise, we expect the blood pressure to go up. And so when we have the blood pressure that is reduced for any reason, we start asking ourselves, is it possible that this person has an extensive coronary artery disease? The context of this patient can have a 3-vessel disease. The patient can have a left main disease. Also, the patient can have severe left ventricular contractile dysfunction. The patient can also have a left ventricular outflow obstruction. In this context, the patient can have an advanced aortic stenosis or even have a hypertrophic obstructive cardiomyopathy, or the person can have hypovolemia. So these are potential differentials for patients that come down with reduction in the systolic blood pressure in the course of the exercise. So thank you very much for that question 33. All right, can I go on, or do we have feedback to give? Or all right, in the absence of anyone, no other question, you can just go into the next one. I will be talking about question 34. So a question is thrown to us, asking us different patient settings, and then the least likely whose cause is due to a cardiac issue. So the first is a 54-year-old man. Of course, this man has congenital bicuspid aortic valve, which is a common cause of aortic stenosis. And this man has, all right, sorry, please. This man has recently noticed shortness of breath while walking his usual 18 holes of golf. So it assumed the man is a regular golf player. And then this man recently started noticing dyspnea on exertion. And this was something he was doing before now. The second was a 70-year-old woman. This woman is old. The woman is an elderly woman. She sustained an anterior MI 1 year ago, and then had a left ventricular ejection fraction of 50% about that time. She has not had recurrent angina, but noted dyspnea during her usual housework over the past 2 months. So it's something they're asking us, is it possible that this woman is having something that is related to dyspnea that is probably of cardiac origin. The fourth is for a 6-year-old woman, and this woman has a history of asymptomatic rheumatic mitral stenosis. Of course, one of the commonest causes of mitral stenosis in the context of our environment would be a rheumatic heart disease. And also, one of the things was that recently she noticed that she's now having irregular palpitations. So the palpitations are irregular, and then shortness of breath while climbing stairs. We now also have a 38-year-old woman, previously asymptomatic. She had an ostium secundum ASD. However, just to note that this woman is 8 months pregnant. And then she has noticed shortness of breath during her usual low-impact aerobics. And then lastly, 22-year-old man with Down syndrome and has a heart murmur who has described shortness of breath carrying ghostly bundles over the past 3 months. So the first patient basically is a middle-aged man, and we know that bicuspid aortic valve, of course, which presents a common cause of aortic stenosis, it often becomes stenotic or progressively stenotic with age. And some of the symptoms would include an angina, of course, would include heart failure, syncope, and of course, the difficulty in breathing that the man is noticing. However, because of what we are seeing in this patient, it's likely that it will be due to the aortic valve disease he has, and it's very interesting to know that this man's difficulty in breathing will just be as a result, will definitely be as a result of probably the aortic valve. So it's likely of cardiac origin. The second person, 70-year-old woman, had an anterior MI 1 year ago, and then of course she's now having what looks like a new dyspnea that has happened over the past few months. And we also know that this patient is likely the current issue maybe due to a left ventricular dysfunction, probably due to ventricular remodeling. Also, just to note that for this patient, angina may be, dyspnea may be an angina equivalent. So it's also important that this patient difficulty in breathing will definitely be as a result of a cardiac pathology. And then also, we've heard about another one, also the 6-year-old person, history of a rheumatic mitral stenosis. And of course, we expect that with time, there will be some issues with the left atrium. We expect the left atrium to enlarge with time. And then also, this may just be that this patient may be having an atrial fibrillation due to the size of the left atrium. And this patient will definitely possibly be that what is happening will be as a result of cardiac origin. We jump to the patient that has Down syndrome, and we find out basically they present with congenital heart defects, which can be present in as much as 50% of patients that have congestive heart disease, and that's that have Down syndrome rather. And then basically they can have issues with ASD, and then they can also have cleft mitral valve, which can also present with mitral regurg. So it means that in the context of what we are talking about, this patient will likely have a cardiac issue. So for patients that are still having an onset of exertional dyspnea, that has happened over the past 3 months, the patient will definitely do well in the best interest of the patient if this patient presents for further cardiac evaluation. Then the last is the answer, which is D. For this 38-year-old woman, she had been previously asymptomatic. However, not to forget that this woman also has pregnant, 8 months pregnant, and of course, it's possible that there may be a cardiac undertone, but also not to forget that this woman is in her 3rd trimester of pregnancy, and of course, due to the impaired diaphragmatic excursion, due to the increasing size of the uterus because of the baby, this may also be a pointer that there may be just all pregnancy related. Okay, so however, yes, things can happen due to the ostium secundum, AST, but this woman also has something at the background, which is in this context, the pregnancy, and then it's something that we'll have to look at the pregnancy. So the least likely, definitely in this context, would be D, which is a 38-year-old woman, previously asymptomatic, ostium secundum, AST, and now 8 months pregnant. So that's basically that for that. So I don't know whether we'll have any other insights before we go into other ones. Thank you. Lastly, we have a very interesting question, and then that is question 35. So this woman, an elderly woman, she has a history of hypertension. She also has a history of dyslipidemia, and she was referred to the cardiologist because of recent exertional dyspnea. And she was also found to have a systolic murmur. Examination findings reveals that the heart rate is normal with a heartbeat of 91 beats per minute. Blood pressure is normal with blood pressure of 117/68 millimeters of mercury. The venous pressure is raised with a venous pressure of 12 centimeter water, and the patient has a grade 3 murmur and is late pitching, crescendo, decrescendo. Of course, this aortic, and then systolic murmur at the upper right sternal border, and then also there's also a problem with the second heart sound, that is diminished intensity, and there's also the presence of bilateral edema. However, just to note that it's very trace. An echo was done for this patient, and the echo revealed mild left ventricular hypertrophy, and then the ventricles, the right and the left ventricles, the systolic functions were preserved. A transaortic valve pressure peak velocity was measured at 3.5 milliseconds, a meter per second rather. And we also say the mean gradient was 29 millimeter mercury, and the aortic valve calculated using the continuity equation. Of course, to achieve this would be to the 5 chamber view. We interrogate the aortic valve using the continuous wave. Then we measure, we trace the valve, we trace the CW. We also put the sample at a pulse wave just at the left ventricular flow tract, and then we measure the left ventricular flow tract VTI. And then, of course, usually in the parietal lung axis view, we are going to measure the left ventricular flow tract the diameter, and then in many in some echo machines, automatically the AVA with the aortic valve area via VTI is measured, And then, of course, we look at the AVA. So AVA, this was not via planimetry method. This was via the continuity equation method. And of course, the calculated AVA was 0.8 centimeters square. Also, the dimensionless index is 0.23. The left ventricular stroke volume index would help us to check the cardiac output. The normal stroke volume index is greater or equal to 35 millimeter per meter square. Of course, this patient was normal. It was 47 mils per meter square. So this patient now did a CT cardiac, and a calcium score was given at 2531 Agatston unit, which is displayed in figure 1.7. The question is, what is your most appropriate recommendation? 1, echocardiographic reevaluation in 6 to 12 months. 2, we do a referral for AV replacement. And then C option is a dobutamine stress test, and then an exercise stress test. Just to put in context. So basically, when patients come in, when we want to make a diagnosis of aortic stenosis, one of the things we need most is the peak velocity measured in meter per second. And this divides using the assay. The assay divides it into mild, moderate, severe, where mild is 2.6 to 2.9 meter per second, moderate 3.0 to 4, so or just say 3.0 to 3.9, because when we say severe, severe means a transaortic valve peak velocity of greater or equals to 4. The patient before us, her peak velocity was 3.5, so brings her to moderate classification. We now go again. There are other things like the mean gradient. Now, the mean gradient is also divided similarly. The mean gradient of less than 20, 20 to 40, or 20 to 39, and then greater or equals to 40 will be severe, while the moderate or intermediate will be between 20 and 39, and then less than 20. Our patient here, the mean gradient was 29, still putting the patient at a mean gradient. Now, we now also have the AVA in centimeter. We now have that the patients that their AVA more than 1.5, those ones are classified under mild. And then we have moderate, which is between 1.0 to 1.5. And then we have severe, which is less than 1.0. So for this our patient, AVA was 0.8, which means that he actually has severe aortic stenosis. However, just to note that is because her AVA is less than 1.0, which gives her severe. However, her peak transaortic valve velocity is less than 4, and then the mean gradient is less than 40 rather, which brings her, now the patient is having some symptoms, which brings us, because she's having recent exertional dyspnea, which means that this our patient actually has symptomatic severe low gradient. Why we are calling low gradient? Because of course the gradient, mean gradient, is less than 40. And so usually for this patient, the patient also has a stroke volume index, which indicates that of more than 35, which indicates the patient has a normal volume output. So the ACT to AHA guideline on valvular heart disease recommends that in patients with suspected low gradient severe aortic stenosis, they go further. The next stage is to measure the calcium score, which is the aortic valve calcium score, via CT, that is via CT imaging, And this helps us to make a definitive diagnosis on the severity of the aortic stenosis. Why? Because this patient is already symptomatic. The patient has severe low gradient. The patient will require us to know where this patient is classed so that we know whether we can advise for the patient to have a valvular replacement surgery done. So for this patient, we now went further, which is what the guidelines support, to go do the cardiac CT to check the calcium scoring. So for the scoring of this patient, we have a benchmark or a threshold for the normal to be, of course, approximately for that age, for that sex, for women, would be about 1,300. And then, of course, what it means is that for diagnosis of severe aortic stenosis, cause greater than or equals to 1,300 for women, and then for men, 2,000 for men. However, for this patient, her score is 2,531, which is, of course, above the recommended unit. So what it means is that this clinches the diagnosis of a symptomatic severe aortic stenosis. And of course, the next appropriate step for this woman would be an aortic valve replacement. Just to note also that in patients with suspected low flow, low gradient severe aortic stenosis, and these patients also have reduced LV ejection fraction, unlike our patient that had a normal LV ejection fraction, a low dose dobutamine, stress echo, or invasive hemodynamic measurement would not be a bad idea to help to define the aortic stenosis as well, the severity. Also, just to note that in asymptomatic patients, exercise stress echo may not be a bad idea. However, patients that do this, we have to be sure that they are asymptomatic, because of course we know that symptomatic advanced aortic stenosis is a contraindication to exercise testing. So we have to be sure that the patients are asymptomatic. It's very helpful to help us, very, very important. However, like I said earlier, once patients have severe aortic stenosis, it will be not the patient's best interest for you to undergo this or deal with the procedure. So with that, I think I come to the end of my questions. So thank you so much for the privilege to be able to have been able to do this. Thank you.
Thank you very much for your doing your part. I have one or two questions. What may explain the low gradient despite the normal left ventricular ejection fraction and evidence of normal flow through the LVOT, as evidenced by the stroke volume of greater than 35 mil that we had? What are some of the reasons why someone may have a low gradient despite having all these parameters that favors a good left ventricular output?
I didn't hear you, please.
So from the scenario, the patient clearly has a normal left ventricular function. The stroke volume is also great, in fact, more than the cutoff of 35, but there was low gradient across the valve, aortic valve, meaning that there's normal flow, but it's the gradient that is low. It's not a typical low flow, low gradient necessarily, if you are going with the stroke volume parameter they've provided. So I'm just wondering, in terms of physiology explanation, what may account for the reason why, despite the good stroke volume from the left side, you are unable to mount a significant gradient across a stenosis aortic valve?
Well, I cannot say, I can't say, but maybe if I could guess, I could talk. Is it possible that the patient is having, because of the calcification, is it also possible because sometimes this procedure, the echo can be observer dependent. So these are possibilities, but that's where I would draw the line. I don't know whether there's other answers to that.
Any contributions from colleagues, seniors? There has been some explanations with respect to increased afterload in such patients, but this scenario did not mention specifically the blood pressure value at the time of the echocardiography, which can also influence.
blood pressure was okay.
Okay, it was
to them.
okay. It's 117/68. So then I'm just wondering why, because the high afterload has been one of the explanations why you may still have a low gradient despite good stroke volume coming from the left. And it's also been said to be in aging people. But it's just a question I'm just asking whether there are explanations, if anyone have explanations for that. In the absence of that, I think, like you rightly mentioned, it's very important that we note the limitations of non-invasive assessment of aortic or valvular stenosis, and we should employ multiple parameters as much as possible in the context of the history. And one good tool to use non-invasively that we can all do, apart from the continuity equation, which has its limitations, like you rightly said, if you make an error in measuring your left ventricular outflow tract diameter, which ideally should be measured in mid-systole, most echoes are done without ECG gating. And without ECG gating, you'll be unable to tell exactly your mid-systole. That's the accurate point for measuring the LVOT. And an error in measuring your LVOT, remember that will be squared because it's pi r squared. So if you make a mistake in your LVOT diameter, it means that the error will be amplified, and that can influence the area you get from the continuity equation. Yes, we understand planimetry is preferred, but planimetry is not possible in every patient, and tracing can be challenging. So dimensionless index should be something that practically, in the absence of situations where you can do stress echo and others, or the dobutamine stress test, you can use, and definitely if it is less than 0.25, it tells you that you are likely dealing with a severe aortic valve stenosis. So, and that can easily be replicated by looking at the ratio between your LVOT and your aortic valve flow. So that would be my contribution. But I'm still open for contributions for the explanation why this patient will still have a low gradient despite a good stroke volume.
All right.
Okay, so in the absence of any further contributions or additions, thank you very much, Dr. Ovunda, for your We're going to Dr. Udeneka Chimezi. Please, are you on? Okay, so do we have Dr. Okedara Ojualepe? Dr. Okedara. Okay.
Hello, I'm around.
Yeah, hello.
I'm around. Hello.
Yeah, Dr. Okedara.
Yes.
Good evening.
Good evening.
Thank you. So 41 to 45. Okay.
Okay. Thank you. Okay, question 41. Which of the following statements regarding intracardiac shunt is correct? A. A left to right shunt should be suspected if the difference in oxygen saturation between the superior vena cava and the pulmonary artery is 3% or more. The oxygen saturation in the SVC is normally higher than that in the inferior vena cava. C. In a suspected atrial septal defect with left to right flow, mixed venous oxygen content should be measured at the level of the pulmonary artery. D. A pulmonic to systemic blood flow ratio QPQS greater than 1 indicates a net right to left shunt. E. pulmonary artery oxygen saturation exceeding 80% should raise the suspicion of a left to right shunt. Okay, so as a form of preamble, the oxygenated blood comes to the right heart while oxygenated blood flows out of the left heart. Normally, there is no communication except you have congenital issues where you have ESD, causing, or you have a PDA causing a flow between the right and the left heart. So the first option saying a left to right shunt should be suspected if the difference in oxygen saturation between the superior vena cava and the pulmonary artery is 3% or more is false. I think for this option it should be about 8%. If it is more than 8%, that should be the figure for that, because a left to right shunt means that there's a flow from the left heart to the right heart, and meaning that you have oxygenated blood mixing with deoxygenated blood, and then what is in the pulmonary artery would be 8% more than the oxygen concentration in the superior vena cava. So that makes option A false. Then option B. Sorry, can you please scroll to option B? Option B says oxygen saturation in the superior vena cava is normally higher than that in the inferior vena cava. That is false. The oxygen saturation in inferior vena cava is usually higher than that in the superior vena cava. I know that there is a lot of oxygen extraction by the brain from blood coming from the brain down through the SVC. So more than what is extracted that's coming from the inferior vena cava. So it's the opposite that's true. So this option is also false. Then C, in a suspected atrial septal defect with left to right flow, mixed venous oxygen content should be measured at the level of the pulmonary artery. I think this is also false. The point at which the oxygen content is measured, I think it's still in the upper right atrium and not at the level of the pulmonary artery. Then option D, a pulmonic to systemic blood flow QPQS greater than 1 indicates a net right to left shunt. This is also false because normally this should indicate a left to right shunt if the QP is greater than the QS, that is the flow through the pulmonary is greater than the flow through the systemic, which means that there is a volume of blood coming from the left side to join that in the right side, making the QP to be greater than the QS. So the ratio will be greater than 1. So it should be net of left to right and not right to left. Then option E says pulmonary artery oxygen saturation exceeding 80% should raise the suspicion of a left to right shunt. This is actually the true option. So if the pulmonary artery oxygen saturation exceeds 80%, it should raise the suspicion that there is a flow from the left to the right. Then additionally, for the QPQS, if we have a QPQS that is less than 1, it is indicative of a right to left shunt. That is what should be the correct one. So if it's less than 1, that is the flow in the systemic is more than the flow in the pulmonary, then it is indicative of a right to left. Then if you have it greater than, you have the QPQS, if it is greater than 2, it's saying that there is a large left to right shunt, meaning that there's a large volume of blood flowing from the left to the right, making the flow in the pulmonary quite much greater than what is in the flow in this systemic. Then if you have it between 1 and 1.5, it signifies a small left to right. So 1 to 1.5, left, small left to right, then greater than 2, large left to right, then less than 1 is for right to left shunt. I don't know that there are any contributions. Okay. I'll go on to question 42.
Hello, good evening. Just a little contribution. You said, okay, I think to classify the left to right shunt, there is a small, moderate, and large. So for the large, like you said, is greater than 2.1. Moderate is 1.5 to less than, that's 1.5 to 1.9, while small is 1.0 to 1.4. Thank you.
Okay. Thank you. Thank you.
Dr. Grim, I didn't hear you, please. Dr. Grim.
Okay, Chief. I said for the classification of the shunt into whether it's a small, moderate, or large using the QPQS. So if it's usually if the QPQS is less than 1.0, it shows that there's a right to left shunt. But once it's greater than 1, it shows that there's a left to right shunt. So classifying the left to right shunt can be classified into small, moderate, or severe. So for a small is when it is 1.0 to less than 1.5. So that's 1.0 to 1.4. For moderate is 1.5 to 1.9, while a large shunt is when it is greater than 2.0.
Thank you so much. I appreciate it.
Thank you.
And usually when it comes to clinical intervention, especially with the left to right shunts, the ones with QPQS of greater than 1.5 are mostly considered significant, requiring intervention. So if there's a cutoff to also remember in terms of surgical intervention or intervention in terms of closure of a left to right shunt, then the QPQS of 1.5, we should keep that at the back of our minds.
Thank you, Chief. So I'll proceed to question 42. A 46-year-old man with dyspnea on exertion is noted to have a systolic ejection murmur along the left sternal border. And echocardiogram is obtained. Figure 1.9 shows Doppler pulse wave interrogation of the left ventricular outflow tract recorded from the apex. Which of the following recommendations would be most appropriate? Okay, so this image Doppler pulse wave interrogation of left ventricular outflow tract shows a late systolic accentration, which is in keeping with the what's popularly known as the dagger shape that is typical in hypertrophic cardiomyopathy. And now this question is saying that which of the following recommendations would be most appropriate? A, strict fluid restriction. B, avoid volume depletion. C, aortic valve replacement. D, bed rest. So I'll strike C out. There's nothing wrong with the aortic valve in hypertrophic cardiomyopathy. It's a dynamic LVOT obstruction that they have. So it cannot be aortic valve replacement. I'll strike bed rest out. So I'm left with A and B. So what are the things that make the murmur more obvious or that worsen the clinical condition? Will be a reduction in preload. Also, if we have so what we need to do is to avoid volume depletion. So we say that diuretics is not advisable in them. ACAI is not advisable in them. So the answer would be to avoid volume depletion. Strict fluid restriction is going to worsen it. So B would be the correct option. Thank you. I don't know whether there are any contributions.
So just can I just ask what are drugs that we can avoid in this kind of condition? Let's say this patient is hypertensive. What drugs do we avoid?
angiotensin converting enzyme inhibitors, diuretics. Those are the ones I can think of. Because the things that would worsen it include volume depletion, that is a reduction in preload, then also an increase in afterload. So ACI will increase afterload, diuretics will reduce preload.
So can you let us briefly take us through some of the maneuvers that may accentuate or reduce the MEMA associated with hypertrophic obstructive cardiomyopathy?
Okay, I think not sure whether Pascal maneuver. I'm not sure actually. Trying to remember maneuvers that will reduce preload and increase afterload. I think hand grip would increase afterload and Pascal maneuver will reduce preload. I'm not sure. I welcome assistance.
So, with respect to hypertrophic obstructive cardiomyopathy, it is essential to know some of the maneuvers. Like you rightly said, anything that decreases preload indirectly can accentuates the MEMA because it worsens the LVOT obstruction. So, for example, you mentioned dehydration or standing from a squatting position. So, when you stand from a squatting position, essentially your preload will drop. That can accentuate the MEMA. Whereas if you squat, that increases the LVOT diameter and improves the flow. Rather, increasing the afterload rather helps with the preventing the LVOT to collapse. So like a hand grip, for instance, increases the afterload and helps open the LVOT up. And so the MEMA will reduce with maneuvers that increase afterload, such as hand grip. So if you have any maneuver, try and put it in the context of, is this maneuver increasing preload or reducing preload? If it is increasing preload, then it's going to reduce the LVOT obstruction, and therefore the MEMA intensity will reduce. However, if it's decreasing preload, then it's going to increase the risk of the LVOT obstruction and so accentuate the MEMA. Whereas if you increase afterload, that increased afterload keeps the LVOT open and decreases the risk of the LVOT obstruction and thereby reduces the intensity of the MEMA and enhances flow. So you can look at it in that context when it comes to the maneuvers.
Thank you. Thank you very much.
Sorry, please, I have a question. So if is this ACEIs are said to increase afterload, so why should they be avoided in the HOCM if they are going to reduce the MOMO? That is, they're going to increase the flow. So sorry.
So it was just so when he mentioned it, I wanted to tell her it was the reverse. So in HOCM, rather an increased afterload rather helps in preventing keeping the LVOT open. But if we reduce the afterload significantly, that rather worsens the LVOT.
Thank you.
Okay, thank you. Question 43. Which of the following statements regarding echocardiography in pericardial disease is correct? A. Small pericardial effusions tend to accumulate anterior to the heart. This is false. Small pericardial effusions tend to accumulate posterior to the heart, that is over the free wall of the LV, that is posterior wall of the LV. Then B, up to 100 ml of pericardial fluid is present in normal individuals. This is also false. It should be between 30 to 50 ml is the normal pericardial fluid. C, in cardiac tamponade, right ventricular diastolic collapse occurs less frequently if pulmonary hypertension is present. This is true. Right ventricular diastolic collapse, as we discussed yesterday, is specific for cardiac tamponade. However, if there is pulmonary hypertension, this signifies raised intra-right ventricular pressures and will be like an opposing pressure to the pressure coming from outside, from within the pericardium. So that's why this option saying that the collapse occurs less frequently if there is pulmonary hypertension. Then D, in the presence of a pericardial effusion, right atrial diastolic indentation is a more specific sign of cardiac tamponade than early diastolic collapse of the right ventricle. This is false. The early diastolic collapse of the RV is more specific compared to the right atrial diastolic indentation. Then E, transthoracic echo is superior to chest computed tomography as a means to accurately measure pericardial thickness. This is also false. Computed tomography is more superior in measuring pericardial thickness compared to echocardiography. I welcome contributions at this point.
This is also a high yield question. The right ventricular diastolic collapse being more specific and the right atrial collapse being more sensitive. So it's also a high yield question that seems to replicate itself.
Thank you. So I'll proceed to question 44. Which of the following statements regarding nuclear imaging in cardiac disease is true? A, the use of single photon emission computed tomography with electrocardiography gating has no impact on the specificity of nuclear testing in women with attenuation artifacts. So we answered the question yesterday that touched on this. So SPECT is the most common imaging that is done in nuclear cardiology, and it actually helps, particularly the SPECT with electrocardiography gating, can help to increase the specificity in women with attenuation infarcts from the breast tissue. And that is why that particular image that we look for, those of us that were around yesterday, that we looked at, that by the time they were doing the electrocardiography gating, it was showing there was adequate contraction. Looking at the systole compared to the diastole, there was still adequate contraction, even though there was this fixed defect in the stress and the exercise by the time we were looking at the different tomograms. But by the time we did we saw the electrocardiographic gating. So the answer for that option was that it was a breast attenuation artifact for the patient in that question. So because by the time electrocardiographic gating was being done, there was adequate contraction, even though there was a fixed effect when there was stress and exercise being done. So for option B, exercise nuclear stress imaging rather than pharmacologic stress testing is the preferred diagnostic modality for patients with left bundle branch block. This is also false. For patients with left bundle branch block, it's preferred to do pharmacologic testing rather than exercise testing with drugs like adenosine, dipyridamole, they are vasodilators, and so it is preferred because if exercise nuclear stress imaging is done, you might still have a false positive in such patients with left bundle branch block. So it's preferable to do pharmacologic testing. For C, the presence of reversible defects on pharmacologic stress perfusion imaging before the presence of reversible defects on pharmacologic stress perfusion imaging before non-cardiac surgery predict an increased risk of perioperative cardiac events. But the magnitude of the risk is not related to the extent of ischemia. I'll still leave this. I'll go to the next option. D. Cardiovascular event rates are similar in diabetics compared to non-diabetics for any given myocardial perfusion abnormality. This option is false. Diabetics known to popularly have multivessel disease, they have higher risk for cardiovascular events than their non-diabetic counterparts. So this makes this option D false. Option E, viability of non-contracting myocardium can be accurately evaluated by thallium 201 imaging. So in terms of radio tracers, thallium 201 was the first that was introduced. Then after that came technetium, which is more effective and more accurate than thallium 201, imaging. So I'll say for this question 44, I'm between option C and E. I'm not too sure. I welcome assistance here. I'm between options C and E. I know that thallium 201 is used. Technetium is also used, even though technetium is more effective than thallium, but thallium is still being used. So I can't say because of that E is false.
So, like you said, the E is the correct answer, but the C, what makes the C the wrong answer is the second part of the statement. So, the presence of reversible defects on pharmacological stress perfusion imaging before non-cardiac surgery predicts an increased risk of perioperative cardiac event, but the magnitude of the risk is related to the extent of ischemia, and they made it is not. So,
okay, it's not.
yeah,
okay.
So that is what makes that statement wrong. It's the second part of the statement.
Okay.
So the correct answer is D.
Okay, thank you. Okay. Can I proceed to 45? Okay, 45. A 45-year-old woman was referred for exercise echo because of a history of intermittent chest pain. She has a strong family history of premature coronary artery disease, but no other atherosclerosis risk factors. The exercise echo achieved the desired heart rate goal and demonstrated a focal wall motion abnormality of the left ventricular anterior wall at rest, which was unchanged at maximum exercise. A subsequent cardiac magnetic resonance study was performed to characterize the myocardial tissue in that region. A delayed image taken after intravenous administration of gadolinium is shown in figure 1.10. What is the most likely cause of the anterior wall motion abnormality? Okay. The image.
Eugene, I don't think this is the
the
picture
image
for this one.
Sorry.
You showed it earlier.
MRI.
What figure was it?
MRI.
It's the MRI. You showed it earlier.
Oh, okay, it's up. Oh, sorry. Okay, this one. Can you see it now?
Okay,
Hello?
yes, I can see it. Okay. I can see, I would need assistance here. But in the septal area, I can see a whitish part, which I think is late gadolinium enhancement. So, and I can see that there is also a darkish curve over that white part. So, like, what is termed subendocardial gadolinium enhancement. So, I will just give a brief talk about just a background talk about the protocols in MRI. So usually the principle is that the MRI images the abundant hydrogen nuclei in the human body, and so it's a multi-component imaging. It has a multi-component imaging capability of the cardiovascular heart. So for structural and physiological information. So then also the gadolinium-based contrast agents are the ones that are commonly used for this. So when injected as an IV bolus, it transits through the cardiac chambers and coronary arteries over 15 to 30 seconds. So that's what's called the first pass phase. Before it now diffuses into the extracellular space, at approximately 10 to 15 minutes after injection, a transient equilibrium now exists between the contrast washing and in the extracellular space and the washing out to the blood pool. So myocardial perfusion CMR and most MRA scans are performed during the first pass phase, whereas late gadolinium enhancement images are obtained during the equilibrium phase. So this image is said to be obtained during the late gadolinium enhancement stage. So for myocardial infarction or coronary artery disease evaluation, so the image is usually obtained during the late gadolinium enhancement stage. And what I can see is that whitish area over the IBS in the septal area that is described as a latent gadolinium enhancement. So looking at the option, I think the option that will be correct for this option 45, question 45 is previous or prior myocardial infarction. That will be option B. But I'm sorry, time didn't permit me to be able to check what the others would show, the other options. Because that could have helped. I don't know if anybody can assist me. What the others would, what would be seen for the other options on MRI.
Please, can anyone help us with the findings, if you know, the cardiac MRI findings with respect to the gadolinium uptake in the various pathologies? Whilst we wait for contribution, I think another thing here before the cardiac MRI, that helps to tell that it's a previous MIs. If you notice, the focal wall motion abnormality persisted at rest and also was at rest and on exercise. It means that it was not induced by the exercise or the stress. So that also gives you a clue that this is something that had already evolved. Any contributions from colleagues with respect to the gadolinium findings in myocarditis, infiltrative cardiomyopathy, and the other options? Okay, in the absence of that, I think Dr. Kedera can check up on that and tomorrow just update us briefly before we continue. Thank you, Dr. Kedera. Do we have Dr. Omokorede?
Okay. Hi. Good evening. Good evening, everyone. Good evening, our chiefs. I'll be taking question 46 to 50. Okay, so question 46. Which of the following statements concerning the echocardiographic evaluation of aortic stenosis is true? And many of these things we have actually discussed it this evening. The peak-to-peak gradient measured at cardiac catheterization routinely exceeds the peak instantaneous aortic valve pressure gradient assessed by Doppler echocardiography. Patients with impaired LV function may have severe aortic stenosis as determined by the continuity equation despite a peak outflow velocity of only 2 to 3 meters per second. Among Doppler techniques, the most accurate transaortic valve flow velocity in aortic stenosis is measured by the pulse wave Doppler imaging. The greatest degree of error in the calculation of aortic valve area using the continuity equation resides in the inaccurate measurement of the transaortic valve flow velocity. And option E, the mean aortic valve gradient measured by Doppler echocardiography is typically higher than the mean gradient measured by cardiac catheterization. So we've discussed some of these options this evening, and we know that the ways of assessing the flow across aortic valves to assess the severity can be done in different ways. We can actually do it through our transthoracic echocardiography. It can be done through cardiac catheterization, and it's been found that the measurements during cardiac catheterization is usually similar. And it's been explained by the fact that even most of the textbook measurements, they're not really emphasizing cardiac catheterization because the echo is sufficient enough to at least almost accurately determine the severity of or the degree of the stenosis that you have in patients with aortic stenosis. And like we also mentioned earlier, that the fact that the presence of an aortic valve area of less than 1 is what we use when we are assessing the structure by the time we measure the aortic valve area. So it's less than 1, we know that that is severe. But the fact that the velocity across that valve is less than 40, we know we expect severe AR, the velocity across to be as high as 60, the mean gradient across the valve. So even if you have a mean gradient of less than 40, especially in the presence of low ejection fraction, so you can say in such patients or in such low flow, because the EF is low, so the pressure of area severe. So that's
Hello? Hello? Please,
Yeah, Eugene, I hear you.
yeah, can you hear her? I can't hear her.
No, her line was breaking and then she's gone off now.
Oh, okay. Let's wait briefly. I'm sure she will get back on. Otherwise,
yes. Hello.
yeah, she's back on.
Sorry, I had a network glitch. Yes, I'm back. So we know that severe the aortic valve gradient is usually less than 1, while the mean gradient for mild is usually less than 20. For moderate is 20 to 30. For severe is more than 40. Very severe can be as high as 60. And then if you have low flow, low gradients, that's in the presence of ejection fraction less than 50, the gradient across the valve might just be around 40, even less than 40. And then also the jet velocities are there, 2 to 2.9, 3 to 3.9, and then greater than 4 for severe. So let's go to the options. So the first option, the peak-to-peak gradient measured at cardiac catheterization routinely exceeds the peak instantaneous aortic valve pressure gradients assessed by Doppler echocardiography. Usually they give like similar readings, so it doesn't exceed it. They're usually like similar readings when you do cardiac catheterization. So patients with impaired left ventricular function may have severe aortic stenosis, as determined by the continuity equation, despite a peak outflow velocity of only 2 to 3 meters per second. So that is true. So that what we call the low flow, low gradient. So the area might be less than 1, and then the flow across might actually be lower than expected. Among the Doppler, so option B is correct. Among the Doppler techniques, the most accurate trans-aortic valve flow velocity in aortic stenosis is measured by the pulse wave Doppler imaging. It's usually continuous wave Doppler that we use to assess the aortic valve. The greatest degree of error in calculating aortic valve area using the continuity equation resides in the inaccurate measurements of the trans-aortic valve flow velocity. No, it is the LVOT, which was also discussed. Meaning that if you don't pick it up at the mid-systole, if you miss that measurement, it's going to significantly affect your assessment of the aortic valve. So option E, the mean aortic valve gradient measured by Doppler echocardiography is typically higher than the mean gradient measured by cardiac catheterization. That is also not true because they give similar readings, especially when they're both properly done. So for question 46, option B is the correct answer. Any questions, contributions, or comments? So I'll go to number 47. Please, can you help me scroll to number 47?
I'm already there. I think probably there's a lag with your
Okay, there's a lag. Sorry. Thank you very much. So, which of the following statements regarding the assessment of intracardiac shunts during cardiac catheterization is correct? This has also been discussed. So, in normal subjects, so let's just a brief overview. So, cardiac catheter, we want to know the QPQS. P is pulmonary system. S is systemic circulation. So you want to know the gradient across the pulmonary vasculature and then compare the ratio of the gradient of flow in both circulations. So you should not, the gradients across, the pressure across the two systems should be around 1 or even less than 1. So it should be around 1, I think it's 1. So by the time you start having shunts of more than between 1 to less than 1.5, so you're having probably mild shunts, or once you start having shunts of more than 1.5, so that's an indication that you need to actually fix. That means the pressure on by the time you look at the pressure in the pulmonary circulation is going up. So you do QP over QS. I just try to figure it out so that the pressure in the pulmonary system is increasing. And then, so you're getting values as high as 1.5. That means you have to fix that shunt so that the pressure in the pulmonary system will not be extremely high. So once you have QPQS more than 2, then you know that significant pulmonary hypertension is actually setting because the QP, which is the numerator, is extremely high for you to be able to give you that ratio of 2. That's the layman's way. I just try to put it in my head. So we'll go to the options. So in normal subjects, there should be no difference in oxygen content in different portions of the right atrium. So this is actually false because in right atrium, we have blood coming in from the superior vena cava and then the inferior vena cava and then the coronary veins. The concentration of blood in the superior vena cava, the oxygen saturation is lower because the brain utilizes more oxygen and compared to the inferior vena cava. So there's usually some subtle differences in the gradient. By the time you now dilute it with that coming from the pulmonary vasculature, so there's this mixture of different blood coming. So at different portions of the right atrium, you might actually have different oxygen saturations at those places, but it should not be more than 7 to 8. So if you're having differences, like was mentioned in an earlier question, of 3 is still acceptable due to the differences in the saturation from all the vessels supplying or draining into the right atrium. So option A is false. Because of the normal variability in oxygen saturation, shunts with pulmonary to systemic flow ratios of less than 1.3 at the level of the pulmonary artery or the right ventricle may escape detection by oximetry run analysis. So if we look at this now, by the time we want to assess the oxygen saturation in the pulmonary system, and then you want to compare with what eventually gets to the right ventricle, due to this mixing, if the shunt is not the change in the saturation is not significant enough, it's possible to miss it. Because if you take the sample that you want to use in the right from where the IBC is, actually oximetry will be higher. So it's a possibility. It's been found that if it's less than 1.3, the QPQS shot less than 1.3, you can actually miss such shunts, even from cardiac catheterization, if it's not so significant. So that option B is true. When a shunt is bidirectional, the magnitude can be calculated by the difference between the pulmonary and systemic blood flow, that's a QP minus QS, as determined using the Fick's equation. Like was earlier discussed, I actually didn't even get the explanation to this question properly, but if I'm correct with the way the explanation was done this evening, Fick's principle, if you have regurgitation or movement of blood that is not giving the direct flow that you want, it will give you some errors in using it to accurately measure the differences in those flows. So using the Fick's equation, you might not actually get the right measurements because of that movement, especially considering the fact that it is bidirectional. So it's not going to give you the accurate error. So this use of Fick's equation in this option is actually going to be false. 47D. Sorry, my network is still lagging behind. I'm not seeing the options. Okay, so 47D. In patients with pure right to left shunt. So by the time you have a pure right to left shunt, the QPQS should be greater than 1.0. That's 1. No. If you have a right to left shunt, I think the QPQS will actually be very high because the pressure on the right, that's on the pulmonary circulation, will even be very high to exceed that on the left, and then to lead to a right to left shunt. So it will be as high as 2. So that option D is wrong. Any comments, contributions? I hope I've
I think that D.
Sorry, I didn't get what you said in D, please. Sorry.
D.
The D.
D.
Yes.
The D.
B.
D for
so,
dog.
D for dog.
Okay, D for dog. So I said that the shunts, I hope I got what I read. The QPQS, we know that normal is supposed to be 1. So if you are telling me that your right to left shunt is equals to 1, it makes the option entirely wrong. So if you have a pure right to left shunt, that's Semenga's, the QPQS will be as high as 2.
I think it should be less than 1.
It should be less than 1. Oh, sorry.
You have a right to left shunt.
That was, as I said, I hope I got the explanation because I sometimes I mixed up. But so, I know that normal is 1. Normal is 1.
Yeah, because your pulmonary circulation, pulmonary system circulation should be the same ideally. the volume that
IDM.
is coming in
Yes.
should be the same volume that is going out. But you see, so
Yes.
look at it this way. If you have a shunt moving from right to left, or let's say left to right, essentially what it means is that you are going to have increased flow through your pulmonary vasculature than going through your LVOT. So for example, if you have an ASD where there's a left to right shunt at the level of the atrium, now your left atrial pressures are higher than your right atrial pressure in the early stages. So you're having predominantly blood moving from left to right. Now that blood that moves to the right then will end up going through your pulmonary vasculature. So there's increased flow through the pulmonaries. Whereas you are losing volume that was supposed to move from your left atrium to your left ventricle and then move out of your LVOT to systemic. So at the end, your pulmonary flow will be higher than your systemic flow. So if you do the ratio with the pulmonary as your greater, then the pulmonary will be greater than 1 because systemic becomes the denominator. And the reverse,
yes,
you have where a situation where now blood is moving from your right to your left. It means that more volume will move to your left and through your LVOT, whereas the volume will reduce from your right going to your LVOT and pulmonary. So at the end, the volume going through your pulmonary will be lower than your volume going through the systemic. So your ratio will be less than 1.
Less than 1. Thank you very much. Thank you for that correction.
Please, I would like to go over this
Any other
explanation on
comments?
B. Sorry, this explanation on option B, because I would like to go over it again.
B or D? Dog or boy?
B rather. B for boy.
Sorry, the network is breaking. I can't hear.
The option B. I would like to go over it again. The reason why you said is the likely answer.
I think she's struggling with her networks. But I think essentially what she was trying to say is that because of the relatively subtle difference in the oxygen saturation levels, even within the right atrium, you can have differences of as much as 2%, even within the same chamber. If you have a left to right shunt, that is not significant. For example, significance using the QPQS of less than 1.5. So a shunt less than 1.5 is mild. So in situations where you're having shunts of less than or equal to 1.3, it means that the left to right shunt is not much. So you may not have significant dilution of the right side such that there will be significant difference in your oxygen saturation for you to detect. So where you have a situation where the left to right shunt is not significant, i.e. is less than 1.3 because of the less already the pre-existing difference in even
The
the right
physiological
atrium,
rule, the physiological, yes.
you may not detect that difference because the shunt coming from the left is not enough to dilute it significantly to cause a difference in the O2 for you to measure.
Okay, thank you.
So I think also that we should mention what the significant QPQS ratio
Can
is.
I go on?
So that the person asking this question will be clear.
Thank you, boss. So I think earlier on she mentioned the significance as I don't know whether she's back. She's struggling with the network.
Yes, I'm back. My network.
Okay. So boss wants you to clarify at what value is the QPQS ratio significant. So basically the categorization you can reinforce it.
So that in case they twist this question, the person asking will be clear.
Yes. So usually once is more than 1.5.
That way.
Yes. Once the QPQS is more than 1.5, then it becomes significant. So you should actually start considering surgical intervention. Once it's more than 2, you know that clear-cut pulmonary hypertension are setting, and you must operate or fix whatever such defects whenever they are when they are possible. But once it's more than 1.5, it's significant, then you should actually walk up the patient for surgical intervention. I hope my network is not preventing you from me. Hello, please, did you hear me?
We're hearing you.
Oh, God.
Sorry,
Okay,
please.
so I hope
want
you
to
had
say
the
something,
explanation.
please.
It's 1.5.
I hope we are not
Yes.
mixing this option B.
Can I go on? You're
You
saying
can go on,
something
ma'am.
Please do.
about pulmonary. Okay, sorry. You're saying something about QPQS being greater than 2, showing pulmonary hypertension. I don't think that's correct, because I think it is when it is right to left shunt that pulmonary hypertension has developed. That is the Simenja. So that is when QPQS is actually less than 1 and not greater than 2. I don't know if you understand what I mean.
I think I understand your point, but maybe
But
I'll
that's
say
not.
in between. You can have pulmonary hypertension and not necessarily have Ezimenga. It's possible. So I don't know whether just using that value alone is enough to make a conclusion. But I like clearly, if there's Ezimenga, then the shunt has reversed. So then it will be the ratio. Then would definitely not be more than 1. But I think physiologically can have pulmonary hypertension and not have reversal. So, but as to whether if it's greater than 2, it means that there's pulmonary hypertension with certainty. I can't comment on that.
Yes, I know why she's asking that question. So what would say for when you have like an ASD, you understand, you really need to categorize the patient and calculate the QPQS ratio for the surgeon. So it's the indication for, or how would I put it, for correction, yes, of a shunt will be that the patient has a significant shunt. If the shunt is not significant, do you understand? That means it's likely that the ASD will still be more. So the shunt is not significant, you could as well leave the patient. That is why, in the actual sense, most of these patients might not present early. They might carry their first pregnancy, second pregnancy till term and live their normal life and present later. You understand? When they start having significant shunt. So when the shunt is significant, you operate the patient. You understand? However, when patient has pulmonary hypertension with a reversal of shunt, it's already complicated. It's not easy to operate the patient again. Because if you operate the patient in that instance, there will be, how would I put it, there might be leakage or it might not be successful, being that the patient has already developed the pulmonary hypertension. So that's why most times before they develop pulmonary hypertension, you must operate. But the moment they become, the moment they have pulmonary hypertension, then surgeons are skeptical. They don't want to take patients for surgery because of the complication post-surgery, leaking of the mesh, you understand, because of the pressure. So you might still have a breakdown even of the shunt following suit. So in the actual sense, the QPQS greater than 1.5 shows significant shunt and is an indication for surgery early. But the moment patient develops pulmonary hypertension, then the risk of patients post-surgery is increased. Then you might not want to operate again since there is already pulmonary hypertension. I'm not sure if you get me. So there are other things that you will look for in a patient to ascertain that the patient has pulmonary hypertension. As we go on, we'll still be able to discuss that. There are some other measurements on echocardiography that you have to do to ascertain pulmonary hypertension in the patient. Thank you.
Thank you. So I think we are going to 48, right?
Thank you very much. Let me just press What did you say?
I said we're going
48.
to 48. Yeah, 48. Yeah.
Yes. Okay, so which of the following please which of the following findings during an exercise test is not associated with multivessel or left main coronary artery disease? We've also discussed this evening. So what are the significant findings in exercise stress tests? We know that by the time we are seeing downsloping ST segments, depression, or the horizontal ST segment depression. Those are the significant findings, or you are seeing significant ST elevation in contiguous leads. Those are some of the significant findings generally that we see if you have arrhythmias or if you have failure of the normal blood pressure response that you expect when you are doing exercise stress tests. You expect the blood pressure to increase in response to the exercise. If you're not seeing all of this, then those are some of the parameters that to look into, that the exercise stress test is actually positive, and then rule in the presence of likely and ischemic component. So which, for this question 48, is the not that we actually want there. So the not associated. So let's look at which ones are associated, so that would then rule out the wrong answer. So early onset of ST segments, and we also have to note, let me just, that they want it multivessel. So multivessel or left main coronary artery disease is something we should also take note of in this question. So if you have early onset ST segment depression, which is actually a marker of an ischemic underlying ischemic problem, so that is actually true. For this question, it will be false. Persistence of ST segment changes, even persisting late into the recovery phase, that's showing that there is a significant coronary artery disease in these patients, because it's even persisting all the way to the recovery phase. So that will be true. For this question, it will be false. I will skip option C. The presence of arrhythmias, especially when it's sustained, we need to note this sustained, because non-sustained is actually not significant. So, but the presence of sustained ventricular tachycardia during the exercise stress test is actually significant for significant coronary artery disease. And then when the blood pressure fails to actually increase by at least 10 millimeters of mercury, so that will be true. For this question, it will be false. So for this question, the ST segment elevation in lead AVR. So what I found is that ST segment in AVR might be seen in other conditions, not necessarily in left main coronary artery diseases. So it is not really, it's not a finding that that is necessarily found in multivessel coronary disease. So you might just see a segment elevation in lead AVR. That doesn't mean that this person has a significant coronary artery disease, but all the other options that are seen here, they are markers of a serious or significant multivessel coronary artery disease. So the answer to number 48 is C. Any questions or comments? So number 49, which of the following statements regarding the auscultatory findings in aortic stenosis is true? So we said that aortic stenosis is a flow across a narrow lumen, and it's an ejection systolic murmur, and anything that would increase blood flow to the left side of the heart and increase ejection is going to actually increase the velocity or the flow across that stenosed or narrowed valve. So which of the following regarding the auscultatory findings in aortic stenosis is actually true? So anything that will reduce blood flow to the left will reduce the murmur of aortic stenosis. So initial squatting. So squatting decreases the intensity of the murmur. So we know that when we squat, there is pooling of blood into the venous circulation in the legs. So it will reduce the eventual blood flow that will get to the heart. So when you reduce the blood flow that will get to the left side of the heart, it's going to reduce the intensity. Initial squatting will actually, that's by the time you are squatting, it will, I said reduce, it will increase because it's when you stand that will pull in the venous system. So when you squat, you are bending down, it will increase blood flow to the left. So squatting will increase flow to the left, and we increase the LV volume, which will increase the intensity of aortic stenosis. So this option is actually going to be false because it's saying squatting decreases. Meanwhile, squatting increases blood flow and it will also increase the intensity of the murmur. So that makes it false. So option B, the murmur is increased in intensity during the strain phase of Valsalva maneuver. So in Valsalva maneuver, in the strain phase, we know that when we try to Valsalva maneuver reduces because there'll be pooling of blood in the splanchnic circulation. So Valsalva maneuver will reduce the blood that would eventually get to the left ventricle. So Valsalva maneuver, especially during the strain phase, would actually decrease the intensity of aortic stenosis murmur. So that option B will be false. So in patients with premature ventricular contractions, so aortic stenosis can be differentiated from mitral regurgitation because there is a bit-to-bit variation in the intensity of the aortic stenosis murmur, while the intensity of mitral regurgitation remains constant. So we know that after a premature ventricular contraction, there's more blood in the LV. So the murmur of aortic stenosis will actually be louder. And usually there is this bit-to-bit variability that occurs because the blood has already pooled and the forward flow, well, the way I could understand, the forward flow is actually not going on because of that premature ventricular beat. So it's not sufficient. So the bit-to-bit variability will be more apparent in the flow across the aortic valve, unlike in the mitral valve. So the bit-to-bit variability would not really affect the mitral regurgitation murmur, unlike how it will affect the aortic stenosis murmur. So this option C is true. So respiration typically has a prominent effect on the intensity of the murmur. We know that respiration has effect typically on right-sided heart murmurs, not on left-sided murmurs because of the increased venous return to the right side. So respiratory typically has a prominent effect on the intensity of the murmur is actually false because aortic stenosis is more of a left-sided murmur. So the answer to number 49 is C. Any questions or comments? Number 50. A 59-year-old business executive presents because of episodes of retrosternal chest discomfort that does not radiate. Let's note that the chest discomfort does not radiate. It is aching, it is burning. Let's note that too, it's burning. Occurs most frequently at night. Occasionally awaken the patient shortly after he has fallen asleep. So we can say that it's not related to activity, it's worse at night. It does not occur while walking or climbing the stairs. So it's not related to activity, it's worse while asleep. Is internist prescribed nitroglycerin, which he has taken infrequently. It does not seem to relieve his discomfort. So if it's angina, we expect that nitroglycerin should relieve his discomfort, but he's not getting that. So let's also note that. So usually it does seem to relieve his discomfort within 10 to 20 minutes. So but it takes it infrequently. But the previous day, that's line, let me read it again. His internist prescribed nitroglycerin, which he has taken infrequently. It doesn't really take it regularly. It does seem to relieve his discomfort, usually within 10 to 20 minutes. Let's just note that too. The previous day during a luncheon, luncheon meeting, he had a severe episode while presenting a new financial plan. The discomfort seemed to lessen when he sat down and finished lunch related to food. The most likely explanation for his chest discomfort is pain that is worse at night, awakening the patient, especially shortly after sleep. So it's not giving us the typical Prinzmental angina usually occurs more at night. We're not told that it has some risk factors for having Prinzmental angina. So if you go to pericarditis, pericarditis, we don't expect that is related to food. The pain should be there, and then if it's unstable angina pectoris, even though they're giving us like it's relieving this discomfort within 10 to 20 minutes, we expect that if he has angina, if it takes its nitroglycerin, will relieve the symptoms almost immediately, because there'll be vasodilation and an increased blood flow to the myocardium. But in this particular question, it doesn't really give that typical picture. So if then the option E is saying biliary colic, nothing really pointing. We expect that is a female. Is he having previous history of stones? Is he fatty males that are worsening it? Is he fair female? Is not the typical things that would push us more to biliary colic is not in this option. So, but let's note that it's immediately after he sleeps. He wakes up shortly, so that's probably after eating dinner. Was relieved by eating lunch. So the answer to this question is actually esophageal reflux and spasms. It's not giving us a typical cardiac or biliary presentation if you look at all these significant findings there. So the answer is B. Thank you. That's the end of my presentation. Any questions or comments? Please, I hope I was audible.
Yes, you were audible. Thank you very much. And it's important to also note that nitroglycerin can give some relief with esophageal spasms. And so that may be the reason why you had a bit of improvement with the use of the nitroglycerin.
Improvement. Okay.
Yeah. So the next person on our list is
thank you,
Dr. Mohammed. Is Dr. Mohammed on? The first name, please pardon me, is S-E-S.
Good evening, sir.
Yes. Good evening.
Yeah. Yes. I'm on.
Yes. Okay. So you're taking 51 to 55.
Yes. Okay. Good evening, teachers and colleagues. I'll be taking question 51 to 55. Question 51. A 44-year-old man with diabetes and strong family history of premature coronary artery disease underwent cardiac evaluation because of episodes of exertional substernal chest pressure. His resting ECG. Sorry, please hold on. Sorry, please. His resting ECG demonstrated normal sinus rhythm and borderline left ventricular hypertrophy. During exercise, myocardial perfusion. Sorry, can you scroll up, Dr. Eugene? Thank you. During exercise stress imaging, he developed his typical chest discomfort and stopped at 3 minutes 20 seconds of the standard Bruce protocol at a peak heart rate of 105 per minute, which is 60% of age predicted maximal heart rate. The systolic blood pressure decreased by 20 millimeters of mercury at peak exercise. Based on the myocardial perfusion images in figure 1.11, which of the following statements is true? So looking at this image, if you look at the top part, the short axis view, you see that for the stress component, the anterior part has a perfusion defect. Yes, thank you. Then if you look at the horizontal long axis, this is the second image down towards the left, you see that the posterior part aspect also has a perfusion defect. If you look down again at the vertical long axis, VLA, you see that the septum is also affected. So, thank you. So, looking at these areas, it means the anterior part of the apex, the lateral, the posterior aspect in the horizontal long axis, and the septal component of the vertical long axis are all affected. Now, question, and then if you look at the resting ECG, myocardial perfusion image, there's no perfusion defect. Now, option A. Just want to go to the question before. Okay, let me just say one or two things about interpreting myocardial perfusion scans. Usually, when you see a perfusion defect at rest, that is not visible during stress. If you see a perfusion defect during stress that is not visible during rest, usually it means the defect is reversible, and this usually suggests a myocardial ischemia. When the perfusion defect is present both at rest and during stress, it means the defect is fixed. And there are two causes of this, either a myocardial infarction or artifacts. And this can be distinguished, whether it's an artifact or myocardial infarction can be distinguished using ECG-gated stress images, where an area of infarction will exhibit abnormal wall motion or abnormal wall thickness, and an artifact will show normal wall thickness or normal wall motion. So for option A, and then another way of knowing if okay, let's just go to option A. There's no evidence of reversible ischemia. So as you can see, I demonstrated both at the short axis, you could see that there's a defect. And I said when such defects occur, it means it's reversible. And then, sorry, Dr. Eugene, can you scroll down? Let me just mention something about the polar image, polar map also. And then to also check for reversibility, using this polar image, these three round images, the middle segment towards the right. Yes. It's the polar map is usually a semi-quantitative segmental scoring system where, or is also called the blackout map, where any location with perfusion values that are below the normal values are marked as black. Thank you, Dr. Eugene. And then areas with abnormal perfusion or during stress that don't meet the threshold for abnormal perfusion are marked with X hatching. And this X hatching is indicative of reversibility. So for option A, that was talking about reversibility, there is no evidence of reversibility. This is false because, as demonstrated, this ischemia is reversible. Option B, transient dilation of the left ventricle after exercise stress is absent. Now, Dr. Eugene, can you scroll up a bit? Let me see the TDI that was quoted there. Okay, so under the short axis, if you look at this value here, TID ratio 1.37. So TID ratio is transient ischemic dilation ratio. This compares the left ventricular cavity size during stress and rest. So normal TID should be less than 1.22 for SPECT myocardial perfusion image and less than 1.19 for PET myocardial perfusion imaging. So for this patient, the value is 1.37, which is greater than the 1.22 for SPECT and 1.19 for PET. So this indicates that there's severe multivessel coronary artery disease, or there's extensive involvement of the left anterior descending artery. So option B. That says transient dilation of the left ventricle after exercise is absent is also false. The increased lung uptake of radiotracer evident on stress imaging is a normal physiologic response. Sorry, Dr. Eugene, can you scroll down so that we'll see the... Okay, so this is the increased uptake of the radiotracer at rest. This black and white looking image at the bottom right corner. So usually when there's a severe left ventricular systolic dysfunction, as a result of severe coronary artery disease or heart failure, there's an increase in pulmonary venous pressure, leading to pulmonary congestion, and then the redistribution of blood and radiotracer into the lungs. This leads to an impaired clearance of tracer from the pulmonary circulation, causing increased uptake. So this, as you can see, this is not a normal occurrence. It's a pathological process. So that makes option C also false. Option D. There's an increased right ventricular tracer uptake on the post-stress image, which is specific marker for multivessel and left main coronary artery disease. I had mentioned this earlier, that when the TID, which is the transient ischemic dilation ratio, is greater than 1.22, it's an indicator for severe multivessel coronary artery disease or extensive left anterior descending. And then looking at the perfusion images, you can see that for the apex, the anterior part is affected, and the anterior part is supplied by the left anterior descending artery. For the vertical long axis, the septum, the whole of the septum is affected. And the proximal part of the septum is usually supplied by the proximal left anterior descending, while the distal part is supplied by the right coronary artery. So even looking at these faces, it shows that both the left anterior descending and the right coronary artery are affected. So option D is true. Option E. The test results are inconclusive owing to failure to achieve the target heart rate. This is false. Poor chronotropic response during stress is indicates it's one of the positive is one of the indicators of a positive stress test. So this is what makes it false. I don't know if there's any contribution or question pertaining this question.
Dr. Mohammed, please, on the this is your option 3, because initially when you were explaining this transient ischemic division ratio, you are using it to say that, okay, if it's more than 1.22, it indicates multivessel disease. But how do you now explain that B option? Because this is talking about dilation of the left ventricle after exercise stress testing. Because that is what you use to explain that option B. Did you get me? Hello?
I can hear you, but I don't know whether he's still on or he's gone off. He's unmuted, but probably he's not hearing you. Hello, Dr. Mohammed. Hello, Dr. Mohammed. Hello? Okay.
I feel it's a network thing because it's on.
Yeah, he's on. Okay. Whilst we wait for him to come back, Dr. Freedom is on duty. He said he may be in and out. I don't know if he's currently on and he can present, fine, but he's on call, so he asked permission. So if he can't, we'll go to the next person. Whilst we wait for Dr. Mohammed to come. Okay, it's actually okay.
11 o'clock, sir.
Yeah, it's 11, yeah. So Okay, I wish Dr. Mohammed was audible so that we could have completed his session. But I think we've still done very well for today, and we are grateful for the contribution and attendance. For the numbers that we could not take, we'll try and finish it up tomorrow. So we'll reach out to Dr. Udineka Chimezi. If someone knows him or her specifically and can reach out to him or her to be around tomorrow so that he can do his or her part 36. I'm using him or her because I'm not certain of the name, whether it is feminine or male. So kindly pardon me. For 36 to 40. And also Dr. Mohammed will finish his tomorrow morning. Then we'll continue with the subsequent parts. With our seniors on, if there are any comments before we call it. Dr. Allison, Dr. Kweki, any comments? Dr. Adeyanju, any comments? Okay.
No comments, please. Well done, everyone.
Thank you. So in the absence of any further comments, I want to say thank you. We'll continue tomorrow, God willing, 8 p.m. Nigerian time. Have a wonderful evening.